All right, I think we'll start with some introductions of the Midwest Tribal Echo team. Dr. Robbie?
Hi, my name is Kari Robbie. I'm a family practice and addiction medicine physician here at NAC. I've been here since 2012, and we really appreciate you all being here.
And then Nikki Jardina is also a team member. She is our syndemic nurse supervisor who couldn't join us today, but she might pop in a little bit later. And then I'm Lindsay King Cooney. I'm the harm reduction program supervisor and also the facilitator of this echo. So I'm going to just do some announcements, share my screen. All right, so welcome everybody to the Midwest Tribal Echo. This is the Opioid Use Disorder Education and Treatment Series. Today we are pleased to welcome back Alice Lehman from the University of Minnesota. So today we're going to be talking a deeper look with a guided discussion and knowledge sharing about congenital syphilis prevention. A little bit about NAC. You're probably mostly familiar with us, but we are an FQHC that was established in 2003. We're located on Franklin Avenue in South Minneapolis, and this is a list of all of the services that we provide here. And then at the bottom is our website if you did want to learn more. And then current open positions at NAC, I won't go through all of these, but again, the website is at the bottom. So if you're interested or if you know of other people that are interested, feel free to send them to our website. And then some session guidelines, please know protected health information. We love to see your faces if you're willing and able to turn your camera on today. And then if you could just let me know who you are in the chat and I can send over appropriate information at the end. This is a list of other echoes that we recommend that cover similar topics on opioid use disorder and infectious disease. If you'd like more information, just let me know. And then our next echo, so we meet the first and third Wednesday of every month at noon. So our next echo is going to be April 16th, and we welcome Angela Richards from Southside Harm Reduction Services, who's going to be talking about the Art Shelf Project. And then finally, case presentations, we welcome and encourage. If you have any to share, please let me know. My email is highlighted at the bottom. And then we'd be happy to set up a case presentation. And I think that's it for me. So I'm going to stop sharing and I will hand it over to Alice. Welcome, Alice.
Thank you, Lindsay. And thanks for having me back. So let me find my presentation here. All right. Do the slides look okay?
Yes.
Great. All right. So thank you everybody for joining today. My name's Alice Lehman. I am an infectious diseases fellow at the University of Minnesota, and I care for children and adults with infectious disease problems. And today I'll be talking about congenital syphilis prevention and using some of the epidemiology data to help guide discussion. I also want to take this chance to thank multiple people at Minnesota Department of Health who have made access to the surveillance data around congenital syphilis available. This includes Kristen, Beth, and Khalid, and I know some of them are on the call today, so thank you. So the objectives of this talk are to examine the extended SETNet congenital syphilis data from Minnesota Department of Health. And I'll talk a little bit more about what SETNet is. And then explore the contributing factors for the epidemiologic findings, and then learn about potential tools and strategies to embrace equitable solutions. And I was at a conference this last week in Winnipeg for providers that took care of Indigenous children, and they use this term self-location. And it's something that I've been trying to think about a little bit more, and I think it has a nice home as we talk about hard subjects like this. and knowing like who we are and what kind of influences are around us and what operations of knowing we work in and what stories they may tell. So I just want to kind of state that I'm coming from the place of an infectious diseases doctor. I have knowledge about the medicine and the diseases, and I have some knowledge about the people I work with and the communities I serve. The epidemiology that we present tells one story with numbers and labels, but people and communities tell different stories that are just as valid. And I know that the audience on these echoes really have a wide range of experience and knowledge regarding the people they serve and the systems they work in. And because of all this, I think we have a really rich opportunity to encourage discussion and sharing of knowledge and experiences throughout this presentation. So I can't see the chat very well, but if things are popping up or you have questions, hopefully somebody can help notify me as we go through this. So I talked about SetNet data. SetNet data is this expanded surveillance of emerging threats to mothers and babies network. It's funded through CDC, and it's an enhanced surveillance that looks at the healthcare of the pregnant person, the delivery process, and then the infant throughout the spectrum of care in order to gain better information about emerging threats to mothers and babies. And so they fund public health surveillance for things like syphilis or hepatitis C, which we know can be transmitted from the pregnant person to the fetus. And then you can see on the map here, these are the states that are currently funded by the CDC to perform SetNet surveillance for different infections. And Minnesota is actually highlighted for CMV. They get funding to do SetNet surveillance for CMV, but they've been actually copied the algorithm and have been doing the same work for congenital syphilis. And so we'll be exploring some of the data from that. And I also just want to say this is amazing work that really informs interventions for us and targeted solutions. And right now we all know that our public health systems are undergoing a threat for their viability. I've already talked to you guys a little bit about the epidemiology at a previous presentation, but just to show you with a visual representation that we are still seeing increased rates of congenital syphilis births. So in the prior decade from 2006, 2015, there were 7 cases of congenital syphilis. And then in the subsequent decade, between 2016 to 2024, there have been 137 congenital syphilis births. Most of them have happened in the second half of that decade. And then the visual representation on the right, there have been 7 stillbirths and then 2 early neonatal deaths also associated with congenital syphilis. When we think about the burden of disease and compare it to the rates of primary and secondary syphilis among females, and the reason why this is important is that primary and secondary syphilis carry the highest rate of transmission to the developing baby, the fetus. However, we also know that latent and early latent syphilis also carries a risk, so keep that in mind. And clearly, as you can see over time with the increasing green bars, we're seeing increasing rates of congenital syphilis. This solid line is the rates of primary and secondary syphilis in females of childbearing age between 15 to 44. And again, you can see our rates are very much higher than they were 2 decades ago. We did see a slight decrease between 2022 to 2023, but regardless, we're seeing increasing rates of this congenital syphilis. And then this slide shows you in the blue bar, pregnant cases impacted by syphilis, and then the green bar shows you congenital syphilis cases. And so you can see that over the last 5 years, we've had consistently pretty high numbers of pregnant cases impacted by syphilis, between 40 to almost 70. but the actual rates of diagnosis of congenital syphilis cases has been increasing. So kind of what we're doing in the meantime isn't necessarily working.
Alice, I don't know if you want me to stop you throughout
Yeah,
with questions.
please.
So Karen just asked, are you also seeing an increase in HIV co-infections?
I would have to, I did not review that data specifically. I know some MDH colleagues are on and they might not know either. To my knowledge, no. But I can double check on that. There's some related risk factors when you think about syphilis acquisition and HIV, but they don't necessarily follow the same epidemiologic risks all the time. Okay, and so this is where we're looking at the number of visits that pregnancies impacted by congenital syphilis had in the prenatal periods. And these are specifically prenatal visits, so seeking some sort of pregnancy-related care. And this is something that is looked at on the birth certificate, and there may be some gaps in that kind of data collection. But knowing of the 50 records they are able to review of pregnancies impacted by syphilis, you can see that over 50% of these pregnant people were seeing prenatal care and had 4 or more visits. About a quarter of people had no prenatal visits on the birth certificate. And then when you think about the timing of the first prenatal visit across Minnesota, 80% of pregnant people have their first prenatal visit usually in the first trimester. But you can see in pregnancies impacted by syphilis, it's all across the board. So a quarter in the first trimester, a quarter in the second trimester, and a quarter having their first visit in the third trimester. And then again, about a quarter of people not participating in prenatal care. When you look at if these pregnant persons had any healthcare visits during their pregnancy, you can see that 63% of pregnant people had 7 or more healthcare visits. So they were engaging with healthcare in other realms. A small amount had 0 healthcare visits, 7%. Of these healthcare visits, where were they engaging in care? And so mostly this was outpatient clinic at 77%. And outpatient clinic includes OB visits, primary care, and specialty care clinics. And then a smaller percentage were engaging with emergency department at 13%, L&D and jail and urgent care. And then we'll walk you through this diagram. This is a flow diagram looking at the missed opportunities in Minnesota of this last year of analysis. And so they had 54 total pregnancies with a congenital syphilis birth in Minnesota. And you can start to see with the 54 over here, what potentially were the missed opportunities. 13% had a late identification of seroconversion. So this means that a person's syphilis test had previously been non-reactive and then became reactive 30 days, within 30 days before the delivery. No timely testing occurred in 46% of these patients, and no timely testing was defined as testing that was not done. That's double negatives. Timely testing was defined as testing that was done less than 30 days before, or sorry, greater than 30 days prior to delivery. So this was testing that was not performed within 30 days of delivery. Of those that did get timely testing, that was 41%. Of those, 11% received no treatment, and then 24% had inadequate treatment. And an inadequate treatment was the dose or the spacing of the dose was not correct. And then of these 54 pregnancies, 6% had timely treatment. And unfortunately, the babies had signs and symptoms consistent with congenital syphilis. So you can see here that really there's a deficit in timely testing, timely treatment, that impacts our ability to prevent congenital syphilis. So the main takeaways from this data, at least that I had, was that many pregnant persons with a congenital syphilis diagnosis are participating in prenatal care and healthcare. And I think historically, there's maybe been an image portrayed of these persons as hard to reach, difficult to find, not seeking care. But I think this data tells us that they do engage with healthcare, and maybe our systems aren't working to capture screening. The second takeaway was that most pregnancies complicated by congenital syphilis had no timely testing or no or inadequate treatment. So again, we're just not doing the screening. And if we do screen, something's not working right, where we can't offer them treatment in a timely way. And then finally, being cognizant of the fact that congenital syphilis rates are increasing despite the decreasing rates of early syphilis. And so I know there was some media portrayed that we're trying to get ahead of the curve, but really we're seeing increasing of disease. So we need to be cognizant of the latent form of this disease for congenital syphilis, and often that is asymptomatic. So I want to unpack these a little bit more, and feel free to say your thoughts in the chat or speak up. But again, thinking about how we are seeing many pregnant people with a congenital syphilis diagnosis actually participating in prenatal care and healthcare. And so when I think about first prenatal care visits, these can be extremely busy and stressful, both for the patient and the clinician, as both are coming at a new pregnancy, and there's a whole to-do list that the provider wishes to do, but also very much a ton of counseling and connection to care that is needed. So these are hard visits. And we also know from epidemiologic data that many congenital syphilis pregnancies are complicated by substance use, incarceration, and disjointed care across different healthcare systems. And so this again is a population where if they are engaging in prenatal care, it might look different than other populations that don't have these structural barriers. And then unpacking new pregnancies in one prenatal visit in a short appointment is almost impossible. And really neither the patient nor the provider is in a state of mind or has the time to counsel about syphilis screening and what it means to be positive. Anybody else have thoughts about unpacking this fact that we found with epidemiology? Keep going. All right. And then from that group, we saw that a quarter of congenital syphilis pregnancies have no prenatal care. Of this cohort, which was 12 people, 4 of those people had no documented health visits. And the remaining 8 people who did engage with healthcare had a total of 12 visits between them, with 5 of them occurring in an emergency department, 4 in outpatient, 2 in L&D, and 1 in jail. And so screening kind of in these traditional prenatal settings obviously won't reach this population who is not engaging in prenatal care. And obviously, I think these people have some barriers reaching clinic, and that carries its own challenges in order to get this population screened. And then I've already talked a little bit about the rates of congenital syphilis are increasing despite decreasing rates of early syphilis. We know that when you look at the overall rates of syphilis, it's decreasing across all by sex assigned at birth, but the proportion of females carrying or that have early syphilis has increased over the past 10 years from 10% to 30%. So there is a higher and now a higher rate among the females as historically compared. And then again, just harping on the fact that early latent and late latent syphilis can still be transmitted to the developing fetus, and that this disease is really asymptomatic. So people will not know they have this unless they're screened for it. And then finally, looking at why most pregnancies that were complicated by congenital syphilis had no timely testing or inadequate treatment. I think a couple things are contributing to this. The fact that the traditional syphilis screening takes greater than 24 hours to return. This is usually a two-tiered test that involves a treponemal and a non-treponemal test with a confirmatory reflex. And so you won't have that result at the time of the prenatal visit and won't be able to act on the result. We know that syphilis screening traditionally is not included in most prenatal bundles that carry the normal prenatal screening. The lack of prior testing and treatment information for a patient is not readily available, especially for patients seeking care in different healthcare institutions. This requires a call to MTH, which can, for some people that are in a busy clinic, be hard to do. And that follow-up treatment visits are hard to complete. There's some data out of Arizona that for patients that are pregnant persons that have latent syphilis, so need the 3 bicillin injections separated by a week, their completion rate, I think, is about like 40%. And so finding these people and bringing them back to clinic is also challenging. So I think as we think about how do we design interventions for these pregnancies impacted by syphilis, there's kind of 3 different populations to think about. So there's pregnant persons that engage in care, there's pregnant persons that are not engaging in care, and then there's all the other people that we should be thinking about who are not pregnant, who play a huge role in congenital syphilis prevention. And so thinking about solutions for pregnant persons who are engaging in care, and again, anybody who's kind of actively doing this or thinking about it, please speak up as I go throughout this. But we know that 76%, again, pregnancies impacted by congenital syphilis in Minnesota had at least 1 prenatal visit. And so I strongly believe that every healthcare system needs a syphilis plan. So every clinic that sees pregnant patients should have a plan to address this, and it should be embedded into the electronic healthcare system to make it easier for the provider, the rooming staff to help get this done. So it's recommended that you embed automatic syphilis testing into every prenatal panel or pregnancy order test. And so that way it will be automatically pop up when these things are ordered. Offering opt-out testing to all pregnant persons. And so instead of saying this is something we could do, just presumptively saying we will be testing for syphilis as an option can capture this better. Embedding MDH's number for contacting for prior syphilis results somewhere in the electronic healthcare system, order set or lab results would be helpful to engage with them early to figure out prior history of treatment, or prior history of testing and treatment. And then I think I've seen this used in a couple of different facilities in Indian Health Service. There's a syphilis tab or flag that's embedded in the healthcare record for the patient that has information about their prior syphilis testing and treatment. And again, this will carry some limitations for the people that are seeking care in other institutions. But traditionally, within each healthcare system, you'll maybe have some record of syphilis testing that you can compare to. And that requires IT support and tech support, but can be done. And then the second point, I think, to think about would be how to utilize point of care testing into the clinical workflow. And so I've previously spoken about the use of point of care testing outside of the clinic and in community-based settings. But there's growing thoughts that integrating the point of care test into the clinical workflow might help bridge some of the gaps that were previously found. And so currently there's 3 point of care syphilis tests that are FDA approved. And you can consider implementing this for prenatal visits. The point of care test can be performed by non-lab trained persons as long as they get the proper training. And so in theory, this point of care test could be done in triage or during the rooming process with perinatal nursing prior to the actual visit. And the point of care test returns within 10 to 15 minutes. And so you'll have an actionable result to help counsel and create planning for next steps by the time the visit happens. And there's actually models for point of care testing reimbursement into clinical work as well. They're starting to do this at the Hennepin County school-based health clinics. To talk a little bit about the point of care tests that we have available in the United States. There's 2 of them, the syphilis health check here, which just checks for syphilis treponemal antibody. And then there's the combined ChemBio DPP, which checks for the syphilis antibody and HIV. And then this is an analysis of the studies that have used point of care tests for various reasons combined compared to traditional treponemal testing. And the sensitivity of syphilis health check compared to traditional screening is about 96% and a specificity of 97. And then the ChemBio, the combined HIV and syphilis test is about 90%, so a little bit lower, and a specificity of 96%. And this is taken from, there's a national congenital syphilis task force who put out a document about how to use point of care testing. And this was a nice graph that they had about how population prevalence can impact the performance of point of care syphilis tests. So for example, in Hennepin County, our rates are on the higher end. So we would be most similar to this box outlined in red. And so assuming the sensitivity and specificity of the syphilis health check, if 1,000 people were tested, you would detect 72 infections, you would miss 3, and you would overdiagnose 28 or overtreat 28. And then you can see the ChemBio performs a little bit worse than the syphilis health check. There's point of care tests are used in perinatal clinics internationally, and the World Health Organization actually encourages their use in perinatal clinics among persons who may not engage in care regularly or high risk for loss to follow-up. And they account for this overdiagnosis or overtreatment as trying to minimize the harm in 1 dose of bicillin versus missing a congenital syphilis diagnosis. And then of the people engaging in care, I think optimizing the use of midwives, doulas, peer support, and perinatal support teams should be prioritized in institutions that have this. There is data out there that community-led and culturally sensitive perinatal programs improve perinatal health outcomes. And we know that the birthing process for Indigenous persons has changed over time and become institutionalized and is traumatic. And that programs that cultivate traditional teaching and values can really be impactful on perinatal health and prevention. And that peer support and people with lived experience are really great advocates for keeping people safe. the same conference that I was at in Winnipeg, there's some people from Nunavut, where the Inuit people live and actually govern their territory. And they are also seeing increasing rates of syphilis, but they have an amazing midwife program for all the rural communities in Nunavut. And they said they haven't had a congenital syphilis case because their cultural midwife program is working so well. I do know that there's some funding barriers for this. And I don't know if anybody's had experience with that and can talk about that aspect.
Yeah, so like for example, if you're an FQHC, you don't actually get any you can't bill for point of care testing. Also, it sort of feels like a part of point of care testing would be to do a blood draw and do the regular testing alongside, so you can get the RPR and kind of before you do the treatment. So it seems like I mean, the way that I think of it, they would ideally be linked to point of care and the send out at the same time. Yeah, I guess but I think the barrier is we've always had to get grant money to provide point of care testing because we can't bill for it.
You're right, Dr. Robbie. So the best practice is to draw confirmatory testing at the time of the point of care test and administer bicillin. That is also a lot to do. And so I think it all can be so protocols should be developed that aim for the best practices. But I know that kind of working with your patient and knowing what their needs are can also lead to some flexibility in presumptive treatment too, especially if you think they might not come back for care. And then your second point about billing for point of care testing, I didn't know that fact that FQHCs can't bill for it in their clinical. There's been like the school-based health clinic also functions with grants, but they're going to be like reimbursing for it based off of health insurance plans. So I don't know if that's something that might work in your future.
No, it doesn't. We're just kind of an oddity.
Okay. Thank you for clarifying that.
Alice, there's another question in the chat from Baba. Would you share any info reference about how syphilis affects the brain?
Yeah. And I guess I'll just clarify, are we thinking about the neonate or the adult patient?
Both.
Both. Okay. Yeah, syphilis affecting the brain is an interesting phenomena. There's actually, so syphilis is a very complex disease in the sense that you have primary, secondary, early latent, late latent. But during all those phases, anybody can have central nervous system or brain effects of syphilis. And when you think about central nervous system syphilis, this could include like a meningitis, so inflammation of the spinal fluid around the brain. And then it could also include eye disease or ear disease, leading to a tinnitus and eventually a loss of hearing and a loss of vision. So there's some thought processes, people that are higher risk for it going to the brain quicker are persons that are immunocompromised or living with HIV, but anybody, and they don't have a good kind of idea about who's more at risk amongst the immunocompetent population, anybody can develop CNS disease. And it's thought that even in these early stages, you can have kind of transient syphilis in the spinal fluid that may go unseen. And so it's always possible at any of the stages of syphilis. If somebody has syphilis that's untreated throughout their lifetime, they can develop late complications, tertiary complications of syphilis of the brain. And those are the ones that can impact memory, behavior, in addition to the spinal cord, and lead to balance issues. But those happen anywhere from like 5 to 10 years after the primary infection. And then as far as the developing baby, the syphilis can be passed to the fetus, and this can impact brain development, have the same impact on brain development, eyes, and hearing as well. I hope that answered your question.
Thank you so much.
Yeah, it's treated a different way too. And so when you have syphilis in the central nervous system, it requires IV therapy with penicillin versus just the bicillin injection. All right. Okay. And then we've talked a little bit about this too. What about pregnant persons not engaging in care? And so there's been a lot of push to screen for syphilis outside of medical clinics, and there's a lot of community organizations starting to do this. And so it's been successful in different communities to have screening opportunities in safe, trusted, consistent places. So certain service programs, health fairs, community gathering places like the Monday event at NAC. You can use either the point of care testing, and I think the funding for this again is mostly through grants. And there has been some historical use of the HIV funding to purchase these point of care tests that you can use HIV funding, and specifically too, you can use by the HIV syphilis dual test. I think the hard part that we're still trying to figure out is the linkage to care for positives. And so critical in this process is working with DIS. If you are able to have them connected to your clinic, mobile health initiatives, and working with MDH. And then these should be offered to all persons, regardless of symptoms, regardless of gender, sex, and that should be normalized and incentivized, and that seems to work. But again, this all depends on grant funding. And then what about screening in other settings like emergency departments? This is actually something we've been trying to work on at the University of Minnesota. And there's some really promising data coming out of Houston from a program called Preg Out. So Houston is seeing astronomical rates of syphilis and congenital syphilis. And so this was a program where they implemented perinatal nursing performed syphilis health check. So the point of care test on pregnant persons in the ED in an opt-out fashion. And so you can look at the program here, pre-implementation. They had over a 6-month period, they had 300 pregnant patients in the ED, and only 6 of these, 2%, underwent syphilis testing. And with this point of care testing and as an opt-out methodology, after implementation, they saw a significant increase. So 79% of the pregnant patients were tested, and about 25% of them. They had a 3.8% prevalence of positive tests, and they were able to schedule 70% of those people with positive tests for follow-up with perinatal care and further treatments if they needed. And then they often interviewed partners, and lots of their partners wanted to be tested using the rapid syphilis health check too. And so I think one area for growth to think about is how can we utilize syphilis self-testing for partners to test remotely and then reconnect to care or in these trusted organizations. And there is FDA approved, the 3rd point of care testing in America that is marketed for at-home testing. Again, it costs $30. It's available online and at Walgreens, and isn't affordable right now. And then the 3rd group to think about is everybody else who's not pregnant And so we know that preventing congenital syphilis requires decreasing prevalence of syphilis in the community. And so MDH has recommended opt-out screening for syphilis at least once for persons age 18 to 49 in routine care. And so this is something to think about as you're creating wellness checks and other clinic-based visits for your populations that you serve. The CDC recommends screening of all people when the rate of congenital or the rate of syphilis among females is greater than 4.6 per 100,000. And so in Hennepin County, our rate is about 15.9 right now. And so I think there can be a clinic or a healthcare system effort to really think about how to embed syphilis screening as a part of annual checkups, STI order sets, mental health visits, MAT visits, and then creating a sense of community collectiveness and clinic collectiveness to help normalizing screening and testing. And so this can be done through commitment posters or screening posters put into the clinic and workplace that can serve as visual nudges for both patients and providers. And that something that we learned during our focus groups the previous year was that people want to talk about syphilis. They don't know much about it. And they said, oftentimes their healthcare providers ask what other questions, but really they just want to be talked at. So talk to your patients about syphilis because they want to hear more. And this will help unpack the shame and stigma associated with the disease. The Northwest Portland area Indian Health Board has an amazing campaign to help reduce syphilis in Indian country. And so they have billboards, they have posters you can hang in your institution, and they have pamphlets and handouts and condoms, snag bags. They have a lot of resources, or at least used to. And they used to have a publicly available website where you could reach out to them. Now you have to log in with a code, but they are worth exploring to get your visual nudges. And then this is just another posing question for people to think about. And then I can take questions.
Yeah, I apologize if I misunderstood something at the beginning, but I just was sort of thinking about it. Isn't the RPR built into most prenatal panels? I mean, they're built into all prenatal panels, I thought.
Are they in yours?
Yes, and when we go to Quest, that's part of the routine prenatal panel that is checked for every pregnancy.
And so I think it's institutional dependent if you run yours in-house and you don't send it to Quest, but it's good to know that Quest does have that built in.
And I just even in my training, that was kind of like that's my understanding is every OB, like that's like one of you fill out the predetermined tests, and RPR is like on that list of things that you screen every pregnancy.
That is the gold standard in teaching, yes. But for example, when we were looking at our prenatal set at Fairview, it wasn't automatically in there.
Really? Wow.
Yeah,
okay, well, that's good to know. I did not know that. That's why actually we've seen them miss sometimes.
Oh, I guess maybe that's why.
Yeah. That's surprising. Thank you.
Yeah.
Alice, I don't know if you want to stop sharing the screen and then maybe we can see if. Thank you. Does anyone have any other comments or questions?
I think I asked this question last time, and I'm going to ask it again. Just in terms of getting the 3 treatment for latent syphilis, if somebody has had one shot, how much protection does that confer for the pregnancy?
Yeah. And so I remember you asking that last time.
Yes.
And it's interesting because as pediatricians, when we evaluate a baby for congenital syphilis, And I'll just say there's differences between the public health definition and then the clinical diagnosis of congenital syphilis. But when we diagnose a baby for congenital syphilis, we use the American Academy of Pediatrics algorithm, which integrates, as you were alluding to, maternal history of labs and testing and treatment, and then integrates infant testing with the RPR that's compared to the maternal or the pregnant person, and then infant exam and laboratory evaluations if indicated. And so historically, what this algorithm used to say was if baby or if pregnant person had not completed treatment greater than 30 days prior to delivery. And so that would allude to the fact of those 3 kind of treatments. Then we put baby into a different risk factor bucket. This last iteration released in 2024 of the Red Book, they now say if initiated treatment. So that means like the first bicillin dose in is initiation of treatment. Regarding your question of like, how does that confer to effectiveness at prevention? I don't think we know because there's no study out there that is demonstrating this. And perhaps that's something that we can extrapolate through better surveillance systems, but I don't think there'll ever be like a study to say is one enough. I think it will put the baby in a different risk assessment bucket now that they've made that change to align with the CDC guidelines. But I don't think we'll be able to say one is enough. And it's very variable. Like we know that early syphilis carries the highest risk, and that latent syphilis is still between like 15 to 20% of pregnancies can be impacted. So I think it would be hard to say like one is enough for everybody, but certainly right now with our guidance, like one changes our assessment of the baby if it's initiated prior to 30 days.
Thank you. That's helpful. And then in terms of like one of the strategies which maybe you mentioned and maybe I missed it is like just the incentives for follow-up.
Yeah.
We have found to be very effective in our setting.
Can you speak how you use that?
An incentive for testing, in outreach events especially, and then incentive to return for results and for the entire series. So patient would get a gift card for the first shot and then for every shot after that, so that they're incentivized to come back. And then additionally, which I think helps, we have a regular event where there's other incentives at that event, though, so that other people around them are also going to the event, so that it's like it's sort of like a thing to do on a Monday afternoon.
And the embedded DI.
Yeah, and then of course, having embedded DI who's able to look up our data for us is very helpful.
Yeah.
I know everybody can't have that.
I wish. If it was used respectfully.
Yeah. It does make me think that it might be a thing to consider checking on every pregnant patient that comes in, just checking meds and making sure that we're not missing anything for some of our patients who come in for their positive pregnancy test, just checking that data.
Yeah.
There's another question in the chat from Amber. Is there any need and change of treatment for persons pregnant with multiple babies? Does this vary by stage of syphilis?
You're talking about like a multi-parity, so lots of, okay. Not to my knowledge. I will confirm that, but not to my knowledge, it does not change treatment. And does this vary by stage of syphilis? So you again would kind of go by the guidance of the early syphilis, the single injection of the bicillin, and then latent, the 3 injections, still with the guidance separated by a week with a wiggle room of like a couple of days as best practice.
It's also possible that the question refers to a dose difference for multiples. I'm not sure. Amber, did you want to?
That's an interesting
I guess
question.
I'm just talking about in general, like when people who are pregnant with twins or triplets, would the need for treatment increase or would it continue to stay the same? And because it's more likely for any kind of effect to take place if it's a primary stage, would you take higher precaution in treating um person pregnant with multiple babies with more doses of Vicillin or no? Or how would that impact like the efficacy of the
Yeah,
treatment?
no, that's an interesting question that I don't think it changes what we do, but should we? Um, but
My understanding is it does not change what we
yeah,
do. Yeah.
but it's an interesting question, like the volume of medication going to the babies. But yeah, it doesn't change to my knowledge. The other thing we know is that like treponema pallidum is like penicillin is wonderful and like kills the infection very well. So especially in those like early stages, it's more amenable to treatment. I'm kind of thinking it might be good to talk a little bit more about like syphilis, the disease next time. Lots of questions are coming up about that.
Well, thank you, Alice. Does anyone have any other questions, comments?
Thank you so much for coming again. It's really nice to get the deeper dive.
Yeah, of course.
This is Jean Larson. I primarily work in HIV prevention, but have always been very interested in congenital syphilis. And I guess what I'm really thinking about is sort of an earlier slide, Alice, when you talked about, the people that engage and the people that do not engage. And so I've been thinking about that for the last couple of days because I'm reviewing a record right now for HIV and thinking about, you know, it was a hard situation, but what I loved is that this person kept going back. She didn't go back at all the recommended visits, but she went back a few times and she actually got really good care. There was substance use involved and she got, they made sure she got her substance use treated and she had another comorbid health issue and they made sure she got that treated. And I just, I remember another case where I had to reach out to a methadone clinic, and they actually kept a list of clinics that they felt really comfortable referring their patients to that were not going to, stigmatize this patient because they're taking methadone. And so, um, one thing that came to my mind today, and I wrote it down, it's like I want to go back to that clinic and just thank them for the great care they gave this person because it was really good care. And I think, somehow I'd love to see clinics for who are doing really well get that feedback. And then also, I mean, I realize we can't publish a list like these are good clinics to go to, but that's what I want. I want a list of like these are clinics that are going to take really good care of patients who have complex things going on. And so anyway, I just wanted to share that thought that's going through my brain because I think what worries me the most, and especially with HIV, when people disengage from the care, either during the pregnancy or after the pregnancy, because that's another situation that happens too. They disengage after the pregnancy, and so anyway, I just wanted to share what was on my mind. No question. Thank you for the presentation.
Thank you, Jean. And after I haven't spent as much time in this role and space as you have, but I do think that we know some of those institutions that treat patients respectfully and safely and can encourage engagement. But it would be helpful to make that more known, especially when if we have a better sense of where people are like initially engaging, where then we can refer them to, yeah. And then Duluth area specifically, I think it would be good to map that out a little bit better.
I've seen lists over times. I know that some places, I've heard that some places maintain lists and that they give as resources to patients. I mean, I think it would be great to have a list that even self-identified clinics who feel like that's something that they're interested in welcoming people in for.
Well, thank you again, Alice, for joining us, and thank you, everybody. I think we're at the end of the hour. So yeah, I hope you'll join us again. Our next session is April 16th, and I'll make sure to send out slides from today if that's okay, Alice. Great. Thank you. All right, thanks all. Have a good day.